We're here at the North American Menopause Society at the annual meeting, and I'm speaking with
Stephanie Fabian.
And Dr. Fabian, you are?
I am the director of the Office of Women's Health at Mayo Clinic in Rochester, Minnesota.
Well, that is a cool place in more than one way.
True.
So we are talking today about a presentation that you have, and it's all about something called GSM, genitourinary syndrome of menopause, in women with breast cancer. So first of all, what is GSM?
Well, genitourinary syndrome of menopause is a condition that women often get after menopause, and it's caused by low estrogen levels in women in general. But what it causes is vaginal dryness and irritation and itching and discomfort and pain with sex, but also the urinary symptoms that a lot of people forget about, and that's urinary frequency and urgency and urge leak and even urinary tract infections.
So it causes women just a whole lot of grief.
Yes.
And because they are in treatment for breast cancer, there's a lot of confusion about what they should do to make it better. So maybe you could talk a little bit about that.
Well, I think there are a lot of concerns about women in breast cancer and their treatments for vaginal dryness, because the typical treatment that we've always used is vaginal estrogen. And there are, of course, controversies about whether or not we should be using any type of estrogen in women with a history of breast cancer or those at high risk for breast cancer, because the entire point of treatment of breast cancer is typically at driving estrogen levels far down. So
Right.
Whether it's with an aromatase inhibitor or tamoxifen or raloxifene or other endocrine therapies, the goal is to get the estrogen level low. So when we talk about treatment of GSM, it's classically with a low dose estrogen. So what we do with breast cancer survivors and what this panel suggested, and this whole thing that we're talking about, is a consensus statement by the North American Menopause Society and the International Society for the Study of Women's Sexual Health, or ISWISH. The whole consensus was to say, what do we do here?
Right.
And so everyone agreed that we should first try vaginal lubricants and moisturizers as the mainstay first-line treatment. And those are over-the-counter things. A moisturizer is used on a regular basis to maintain vaginal moisture, and a lubricant is used for sexual activity. But the considerations that we have to think about when we're talking about using vaginal estrogen, the panel agreed that important factors are what stage and grade of breast cancer was this? How long ago was the diagnosis? Was it an invasive cancer or not? What was the receptor status? Does it have estrogen receptors? Has the woman tried the over-the-counter lubricants and moisturizers? Did they fail? What's her quality of life like now? And so, taking all of those factors into account, we decided that in general, the women with less invasive cancers, not metastatic disease in general, hormone receptor negative tumors, more time since diagnosis, poor quality of life, worse symptoms, and failed the over-the-counter hormone therapy or over-the-counter treatments, those would be the women that would be the best candidates for.
So hormones, the estrogen vaginally for women with estrogen receptor negative.
In most cases, but that's not to say it's an all or nothing thing. So there may be certain cases in which a woman may have had an estrogen receptor positive cancer 10 years ago. Is it completely unreasonable to consider a little low dose estrogen therapy? Probably not. But this is in combination, this is a communication between the woman, her provider, and involving her oncologist in the discussion.
Now, there was an opinion piece from the American College of Obstetricians and Gynecologists in 2016 that suggested that even in estrogen receptor positive patients, that women could take vaginal estrogen.
Yes.
If they failed, the other
Yes.
treatments.
And this panel agreed with that decision. So this is really about shared decision making, and it's all sort of weighing risks and benefits out and helping the woman understand what those are. And sometimes for quality of life purposes, it may be worth it for the woman to consider that. But it's definitely an individual decision that a woman would make in combination with her doctor and her primary care doctor and her oncologist.
Is there any stage or situation where it's absolutely a no-no to use vaginal estrogen if you're suffering with all the symptoms you talked about?
I don't think there is ever a black and white no. So I think it's always a consideration, again, after careful discussion. But there's some other options out there too. There's vaginal DHEA now. There's vaginal laser therapies, which we talked about in this discussion as well. So there's a lot of things out there, and they have their pluses and minuses, and all of them require a little more study in this population to figure out really what the true risk-benefits ratio is.
So the bottom line is, it sounds like at the very least, if you have breast cancer, you're struggling with this condition, go and talk to your doctor and get help. There's something out there that you should be able to try.
I think that's the final message, that there is help, and that the majority of women with breast cancer have these symptoms. We estimate it's well over 50%. So the majority are out there suffering, the majority are not getting treated, and there are lots of options out there. So bring it up with your doctor.
Thank you.